So now we shall proceed with the plenary talk. So without further ado, I would like to welcome our next speaker, Professor John Norcini. But before that, a little bit info. So Professor John Norcini is the President Emeritus of the Foundation for Advancement of International Medical Education and Research, or also known as FAIMER. FAIMER has an active research program on international health professions, education, and physician migration, global fellowship programs, and also master's degrees for faculty from health profession schools and databases of recognized medical schools and accrediting bodies around the world. Prior to FAIMER, Professor Norcini had a number of positions at the American Board of Internal Medicine. He has more than 200 publications, lectured and taught in more than 45 countries, and is on the editorial boards of several peer-reviewed journals. He is an honorary fellow of the Royal College of General Practitioners and the Academy of Medical Educators, and has received numerous awards, including the Karolinska Prize for Research in Medical Education. Now, I would like to welcome Professor John Norcini to the floor.
Thank you. It's wonderful to be here today. I'm really delighted. And I want you to know, since this is a relatively small group, that as we go through this, you can absolutely interrupt me. Okay? If you have questions along the way, if I'm not clear, just speak up or raise your hand if you're in the back. Okay? Is the deal? All right. Does everybody know what formative assessment is? Maybe I'll spend just a half a minute on formative assessment to make sure we're clear about it. So when I was growing up, and that was like a lot of years ago, when a teacher assessed me, they always assessed me in order to make some kind of a decision about me. Okay? So anytime I got a test, the results of the test were used to make a judgment. And that's called summative assessment. So within the past 15, 20 years, there's been a real interest in formative assessment. So this is assessment that's designed to help people learn. It's not designed to make a decision about them. So if you do an assessment and you use those scores in any way to make a decision about somebody, it's summative. If you don't use the scores for that, if you use them to provide feedback, then it's formative. So today what we're going to focus on are formative assessments in the workplace. So what we're talking about is assessment that occurs in the workplace, so any sort of clinical training or clinical practice setting. And what I'll do today are talk about, there are dozens of these methods. And so what I'll talk about are what those methods have in common first. Then I'll provide 3 or 4 examples of different methods. I'll talk a little bit about why they're good for personalized learning, and then talk about why they're still good for assessment, formative assessment. Okay? So that's the plan for today. So in all of workplace assessment, there is a person, a faculty member usually, who is observing the trainee in some sort of work activity and making a judgment about them. So one of the ways that this happens often is that the trainee is watched over time. So I might have a trainee with me for a month. At the end of that month, I fill out a form that offers an evaluation of the trainee. So the good thing about that is that it's based on a number of observations of the trainee. So you've seen them several times, and that's a good thing because it gives you a better handle on them. But the other side of this is that sometimes people fill in checklists or rating forms, and they haven't actually seen what it is they're rating. So I don't know what happens here, but in the United States, we used to give rating forms to faculty members, and we asked them to rate the physical exam skills of first-year trainees in internal medicine. Well, nobody watched a trainee take a physical exam, but those forms got filled out anyway. So one of the problems with this is that you don't actually have to see somebody do something in order to fill out the form. The second thing is it's subject to general impressions. So I like my good friend Trudy. She took me out for a beer last night. She's a good person. Okay, so I'm gonna have a generally favorable impression of her, and that's going to influence a lot of what I do. Okay? So that's one way to do this. The other way to do this is observe the trainee in a particular work encounter. So just one, not over a period of time. So you watch them interview a patient, you watch them do a procedure, whatever. So it's focused on an encounter. Now the good thing about that is it's not perfect by any stretch of the imagination, but it's a little less subject to general impressions. Well, I might like my good friend Trudy, if she's not doing well with a particular patient, I'm going to have trouble with that. There's at least going to be a little more dissonance than if I just look at her over a period of a month. So it's a little less subject to general impressions. But the other side of this is that it's not good enough to see Trudy once with a patient. I have to see her on multiple occasions before I can come to some sort of judgment about her. All right, so they're the two kind of ways of two things that are observed. What happens at the end of that is that you have to collect the information from the observer some way, right? And we usually use some forms of checklists or rating forms. So a checklist is simply a list of things that somebody ought to be doing. And this is a good thing if you're a non-expert. So I'm not a physician, but I could sit in and watch a patient and a trainee have a conversation and figure out if the trainee asked about a history of smoking. I mean, even I can do that, okay? So checklists are good. You don't need to have an expert to apply them from that perspective. So from that perspective, they're positive. The other thing is that it makes it really easy to provide feedback. If I've got a checklist with the eight things on it and I didn't do 5, when you sit down with me to give me some advice afterwards, you can just look down the checklist and tell me what I did and didn't do. So it really facilitates the provision of feedback, and that's a positive thing. The downside, though, is it misses all the subtleties in performance. I can't tell you how many times I've been with faculty who've watched a trainee take a history, filled out the checklist, trainee got most of the things, and the faculty member said, this trainee is not very good. You know, they missed all the important things. It's completely disorganized. But they took a shotgun approach. Okay, so one of the advantages or disadvantages of checklists is that it misses the subtleties of performance. An alternative to this are global ratings, where you're asked to judge the quality of a performance. Now, for this, you have to have an expert. I can't sit in a room and watch somebody take a history and decide whether it's a good history or not. So it requires an expert. But the good thing about this is it lets that expert use their judgment. And their judgment, I think, is an absolutely crucial part of the assessment process. And there have been probably in my career 300 studies comparing checklists and global ratings. And basically, the results are highly correlated. But the checklists tend to be a little more reliable, repeatable, and the global ratings tend to be a little more valid. They capture important aspects of the performance. Okay? So you can really use either, but my personal bias is for the global ratings. There's a third way to do this that I don't like very much, but it's used often. And that's where you ask the judge to evaluate the quality of the performance, but then make a pass-fail decision. Was this satisfactory or unsatisfactory? Okay? And part of the problem I have with that is that you're asking judges to push two judgments together. One judgment about the quality of the performance, and the second piece of this is what kind of standards the judge has. So my good friend Trudy has incredibly high standards. My good friend Vishna, not so much. So if they're both evaluating me and I get the same results, I'm not going to know exactly why I got those results. So I'm not too keen on this, but several people use it, and it's certainly possible to use things this way. Now the key to all workplace-based assessment is that after the assessment, the observer provides personalized feedback. And the reason to do this is to provide feedback. That's the whole point here. That's where this works. It's not so much in getting grades. It's in making sure that you provide the right kind of feedback. And I'm sure you've looked at this, but there's a whole raft of ways of providing feedback. But the things that are most important are that as you give feedback, you identify strengths and weaknesses. You encourage the person you're giving feedback to self-assess. At the end of that, it's really important to tell them how to get better. The feedback you give somebody isn't what makes a difference. What makes a difference is what they do in response to that feedback. So what you can do from a personalized learning perspective is you've collected the information, you found an individual's strengths and weaknesses, and then you provide them a way to get better. Norcini, you don't know anything about cardiac dysrhythmias, and so I want you to go read something about that. And the last piece of that is that you need to close the loop. So it's one thing to tell somebody what to do, but it's really important to know that they actually do it. So the last piece of that is, you might say to me, Trudy might say to me, Norcini, what I'd like you to do is I'd like you to read about dysrhythmias. And what I'd like is an email from you in a week that basically tells me what you read. Okay? So Trudy doesn't have to go out of her way. It appears in her box. But that gives me a task. So she's given me a way, she's identified my strengths and weaknesses, given me a way to get better, and then in a sense forced me to get back to her to indicate that I've actually done that. Okay, and that's really the key to the workplace-based assessment things. The other thing that's important here is for all of these methods that I'm going to show you, the faculty are the device. People spend their lives creating rating forms and checklists, and they don't really matter that much. What matters are the people who fill out those checklists. Okay, so in all of these, the methods are the faculty. And as a consequence, it's absolutely critical that you train the faculty because they're the method. So I can't tell you how many people I know who've spent half a lifetime creating a rating form because it's the only thing they really have control of, I guess. But it really doesn't make a difference. You can change every item on a rating form and it is not going to matter. Okay, so faculty are critical to this and faculty development is essential. Everybody good with this so far? Okay, so let's talk about some of the methods, and there are a lot of methods out there. 360, and there are new ones every day. I mean, there are just dozens of these things out there. But what I'm going to do for the next few minutes are talk about the ones in red. They're ones that are used pretty commonly, and they're used commonly across all of the health professions. These are, although much of my experience is in medical education, I've been doing work with nurses and pharmacists and scientists, and these things work pretty well for some of the things that they do. So in a mini CEX, what happens is that Trudy watches me with the patient, 10 or 15 minutes doing a brief history or physical tailored to exactly what the patient needs. At the end of that time, she rates me along a number of dimensions. And then she gives me some feedback. Whole thing usually takes 10, 15, 20 minutes. And the idea is that you would have 3 or 4 or 5 of these through a period of training. Okay? Simple method, right? None of this is rocket science. This is not really very sophisticated stuff. Another thing that folks use quite often is direct observation and procedural skills. And for DOPS, what they do is they're looking at a trainee perform a procedure. So it's just like a mini CEX, only you're looking at the procedure. At the end of that, my assessor rates me along a number of dimensions, provides feedback. Again, these are 15 or 20 minutes long. They're supposed to be short, quick, focused. And the idea is to have 3 or 4 of these through a period of training. Chart-stimulated recall. Do folks know about chart-stimulated recall? So this was started many, many years ago at the American Board of Emergency Medicine. And when the foundation programs came in, my British colleagues don't have charts. They have cases. And so if you look at the literature on this, it's the same as the literature for case-based discussion. Okay, so it depends on whether you were in the US or the UK when this came up. At any rate, what happens is that Trudy comes in with 3 or 4 charts. I take a look at them and decide I'm going to do an examination with one. Okay, so I have a patient record that she worked in. So the first thing I do is I go through that record and look at the quality of the notes. Okay, in the old days when the notes were on paper, you look at the legibility of the handwriting, you look for what was missing, yada, yada, yada. But even with electronic medical records, there are things that might be missing, other things you should have done, pieces that are incomplete, all of that. So the first piece is to look at the documentation, but the more important piece of this is that after that, I'm going to start to ask some questions. Why is it that what was in your differential when you were looking at this patient? What would happen if this symptom was different? How would that change how you prioritized your differential diagnosis? So the idea is that you do a little oral exam. You ask questions to get at the person's reasoning. So the whole point here is to get at documentation and how the students think and how they reason. Okay? These are not long. Again, they can be 10 or 15 minutes. The idea is at the end of that, again, I rate the trainee along a number of dimensions, give them feedback, and there should be multiple of these, 3, 4, 5 through a particular period of training. Okay? Last thing is 360. I think probably everybody in the universe has been exposed to, yeah. You're just discussing one case, but it's a case where the trainee had an interaction with the patient. It's not with you coming in and handing them a case and saying, this is what you did. This is somebody they actually know and somebody they actually worked on. And that's the key to this, because you have a real patient and real decisions to be made. Yeah.
How those cases are selected? Is out of few they submitted, or is it one they choose out of,
So that's a good question for all of these methods, and I'll talk to you about sort of both models. In the U.S., when we did all of these, all the methods that we're talking about, we would ask the faculty to pick the trainee and the patient and do the assessment. Okay? When this got translated to the UK, what they did is they told the trainee to go pick the patient and then come and get a faculty member to do it. Okay? Now, if I'm a trainee, I'm not going to choose a very challenging patient. And not only that, I'm going to choose my favorite faculty member who's always been good to me. Okay? So there's an issue there. On the other hand, when it was done in the US, the faculty members never did it. Okay? So the bottom line here is that you pick your poison. You pick whichever one makes the most sense in your environment. They both have limitations. The good thing from my perspective is that since these are formative, so they're designed to help the student is really at a disadvantage if they find the easiest patient and the easiest faculty member. It's really to their advantage to get a case that's challenging and for me to get Trudy to come in and watch me do that and give me the kind of feedback I need. It's not going to count against my grade, but she's going to be tough with me, and that's what I want. Okay, that gets your question. All right, that starts stimulated recall 360. So some of the ways this has been employed that I'm familiar with is that this is a rating form that's filled out by peers and trainees. So the way this starts is that Trudy comes to me and says, Norcini, I want you to fill out this form for yourself. So I actually rate myself on things like communication skills, timeliness, all those kinds of important things. And then she says, I want you to take these forms and I want you to give them out to folks. And she gives me 5 forms to give out. And so what I do is I find my 5 best friends. Okay, and I give them the forms. And when they're done, they have to go back to Trudy. Okay? So this occurs over a period of time. And then Trudy sits down with me at the end of the time and she says, Norcini, she says, you know, you rated yourself a 9, which is at the top of the scale. She said, you know, the average trainee in this program rated themselves 7. So you really have a, you know, sort of a high opinion of yourself. And then she says, and your 5 best friends, they rated you 4. Okay? I changed my best friends, yeah. It would be good to get a best friend. So, and my friends are saying in their comments that Norcini's never on time. You know, we can't rely on him and he can't be useful. So at the end of this, she sits down with me, she gives me some feedback, and hopefully we repeat this exercise 6 months later. Hopefully when we get to that point, my own self-assessments are a little more accurate. And I've squared things up with my best friends by sort of being reliable and more on time. Okay, so it's a useful formative kind of device. All right. So let's talk about a little bit about the research here. So why are these good for learning? Well, the first thing is, and I don't know what the situation is here, but in the US context, trainees just don't get feedback very much. Okay, there's this wonderful study by Snyder, and he surveyed all of the surgery residents in the United States, and he asked them, you know, how often did the faculty identify for you goals before you walked into the theater? Things you could learn about. 18%. How about areas for improvement afterwards? A third. So trainees are missing all that. And it is not surprising that a year later, when there was a survey of the fellowship training program directors, so these were the folks who took in these trainees, they found that a fifth were unprepared for the operating room. A third couldn't operate for more than 30 minutes unsupervised, and more than half weren't very good with laparoscopic procedures. Okay? So there's not a lot of feedback going on. And just so it's clear I'm not picking on surgeons, same thing in internal medicine. The bottom line here is that in internal medicine, folks aren't being observed. We did a survey of all first-year residents in the United States. We asked them how often they'd been watched taking a history and doing a physical exam. And basically 80% said they'd been observed once and only once during the entire first year of training. Okay? So if you're not watching, you can't be giving feedback. And if you're not giving feedback, you're missing one of the biggest ways to make a difference in what students learn. So there's a wonderful meta-analysis of meta-analyses done by this guy named Hattie in Australia. And he was looking at primary and secondary education. And basically what he did is he looked at what are the biggest drivers for achievement. What is it that makes a difference in when students learn and how much they learn? And what he found is that feedback alone was one of the biggest drivers. In fact, there's something called an effect size. One standard deviation is an effect size of 1. So it's big, it's real big. Feedback alone has an achievement effect of 0.79, so nearly 0.8 of a standard deviation. So it's a huge effect. So if you're watching and you're not giving them feedback, you're missing the biggest opportunity to learn. And there's lots of other data of this kind in medical education, in health professions education. This is a ubiquitous finding. So if you think about workplace-based assessment, what it's doing is it's forcing you to watch, and then it's giving you the opportunity to provide feedback. And feedback is one of the biggest drivers of learning. Okay? So there are two ways. There's something called Mastans space training. There are two ways to teach a course. So if I had an 8-hour course to give, what I could do is I could get you all together for 8 hours and we get it done. That's called massed training. Another alternative is an hour a week for 8 weeks. That's space training. Okay? Which do you think leads to faster learning? Space. What about confidence? Well, you're not answering the question. You read the book already. That's not fair. You saw the answer. So confidence. Spaced. Satisfaction. Spaced. Retention. Spaced. You're getting stronger. I see a trend happening. Performance. Spaced. Not really. So mass training gets you there faster. You feel better? You're more satisfied? Yes. You could be anything you want. Uh-huh. Uh-huh. Mm-hmm. Right. Yes, I think you're right in terms of things like speed, confidence, satisfaction. But if you were to test those students again a year later, what you would find is performance and retention is going to be better. These are not my opinions. I mean, this is based on like hundreds of studies. This work goes back to even before I was born. Okay, so to give you some idea of how long ago it happened. It was the 1890s when they began doing this work. So there really is a history here. But as with all of these findings, it's a probability. Okay, it's not a sure thing. So you're right. So you're better off longer, and you're better off spacing things out. So the key here is, if you think about workplace-based assessment, what you're doing is you're forcing somebody to watch somebody else. You're providing them feedback on that performance. And because these occur spaced throughout a period of training, you're taking advantage of the spaced learning effect. Okay? Last thing is that assessment actually creates learning. There was a wonderful series of studies by these folks, Karpecki and Roediger. And what they did is they had a passage. They started with high school students. They had a passage, a science passage, and they gave it to all the students to read. And then they randomly divided the group in half. This group over here read the paper 3 more times. This group over here took a short test. Didn't get the results of the test, didn't know what the score was, just took the test. And what they found is 2 or 3 weeks later, the kids who took the test 3 times knew more and did better than the kids who read the paper 3 more times. And their hypothesis is that when you want to learn something, it's not just good enough to take stuff in, you also have to practice retrieving it. You have to practice learning it and using it. And so that's one of the things that assessment does. It forces you to remember or to practice or to perform. Okay? Lots more research in this area, a nice one in science. Yeah? Yes. No, they're very sophisticated. This was done about 85 different ways, and there are a whole series of studies, so that it's not just I memorized the questions on the test, walked out the door, looked up the questions, and then came back and did it again. Okay, and in fact, if you see the last publication was in Science, those guys, you don't do that sort of methodology and get away with it and publish in Science. And in fact, the science paper is a little interesting because not only did they have the kids read and take a test, but they also had a third of the kids draw concept maps. So they took all the concepts out and tied them up. And what they found at the end of the day was that the formative assessment was more effective than those other 2 by a substantial amount. It was like 2/3 of a standard deviation. So it's a major effect. Yes? No, I didn't. No, I did not.
I tried concept mapping and asked students to do it, and our students, maybe they are not so used to it. They say they didn't really like it so much because they say that a lot of work.
Right. Yes.
It's a lot of work, and I don't know. In the end, I don't know how much they got from it, but what I know is they still want to fall back to the old one, the mind mapping. So I don't know how concept mapping can work for assessment, but for teaching and learning, I find that it's quite useful.
Yeah, I am agnostic about those maps as as an assessment device. Whatever works. You know, I'm really surprised that the students complain that it was too much work. This young man never complains that there's too much work, does he? Yeah, I know, but so yeah, I'm agnostic about concept maps. So if they work for you, great, and if they don't, that's good too.
Yeah, my question would be, in my era when I was trained, the training was not actually supported with, is it? Okay, the training was not really supported with reflection. That was the part missing in my training, right? I didn't reflect what I learned or I didn't, and how better can I do in future if the similar situation arises. But now the reflection is something which is added on to the training. Particularly, we train them with the experiential cycle and all. But most of the formal workplace-based assessment, I don't see reflection as part of it, except I heard you just now, the feedback and what happened to the feedback. So why this formally is not part of the workplace-based assessment, but I heard from you right now. And that makes the difference, my era training and the current training.
So you need to understand that there's nothing formal about workplace-based assessment. There's nothing sort of set in stone about these methods. So you can modify them in any way that makes sense in your environment. But I absolutely agree. When you go to give feedback, one of the first things you want to ask someone to do is to reflect on their performance. That's the first step to effective feedback from my perspective.
Okay, thank you very much. It was very interesting because I'm not so familiar with workplace assessment. I'm just wondering, since this conference is about technology, Industry 4.0, where is it now in terms of how is artificial intelligence and so on helping out to make it more efficient and effective? And so students, for example, can get feedback on the spot instead of waiting for the lecture to, how can technology help in form of workplace assessment? What's your take on it, or what have you read about it? Or?
So I think Trudy talked a lot today about exactly how the workplace-based assessments could be, and the data from those could be managed. And so I think that's really the future of this, is getting the information back. That said, there is no replacement for you sitting down with me and saying, Norcini, look, these are your strengths and weaknesses. This is what you need to do, and I want you to check back with me. So I'm an old man, okay, and as an old man, I like people, and I like that kind of interaction. And as long as you're going to have to sit there and watch me anyway, okay, it would be awful to, do something, not use you when you're in that situation. I think the real answer to your question is that different people are going to learn different ways, and there may be some students. Many students who would prefer that sort of distant kind of feedback, others who prefer talking to people. So, yeah, good question. Anything else? All right. So let's talk about why these are good for assessment, and then we'll wrap up. So when I was a very young man, and as we already established, that was quite some time ago, I worked for the American Board of Internal Medicine. And what the board said is that the way that they wanted program directors to assess trainees was to give them a clinical evaluation exercise. So in a clinical evaluation exercise, what happens is that my faculty member, Trudy, she runs around the hospital, and it has to be in the hospital, and she finds the strangest patient she can get. Something that would really trip me up because she's that way, okay? Something that would really challenge me. And then she goes back to her office and tells me who I have to see. And then I go in and I do a complete history and physical. I write this all up. I walk into Trudy's office, tell her what I found. She does an oral exam with me. And then she makes a decision about whether I pass or fail. Okay? So the traditional clinical viva. And that was it for the entire first year of training in internal medicine. But there's some problems with this. The first problem is that the trainees evaluated with only one patient. And that's a big problem. Physician performance, in fact, all of our performances are case or task specific. How we do with one doesn't necessarily do a good job of how we'll do with something else. So if you want to get a handle on somebody's ability, you have to see them with 3 or 4 or 5 different patients. So the first problem with this is that there's no sampling. And workplace-based assessment, as we talked about, is designed to watch a trainee with multiple patients. Second problem is that the trainee was evaluated by only one examiner. And examiners disagree even when they're looking at the same thing, the same performance. So there's a great series of studies where a faculty member, Georgetown I think it was, took a video of his trainee with a patient. And Gordon Knoll is the guy's name. Got his faculty together, showed him the videotape, told them they couldn't talk to each other and just evaluate the performance. And so he, to his surprise, some people thought the performance was superior. Some thought it was sort of average, and other people actually thought it was unsatisfactory. So Gordon was really troubled by that, and he basically said to himself, well, it's my faculty. You know, these people are a little crazy. They don't get along very well. So what he did is he took his videotape on the road, and he went to 7 or 8 or 9 different medical schools. And in fact, he found the same thing at each medical school. Okay? There's considerable variability in the way examiners look at a particular patient in an encounter and make judgments about it. As a consequence of that, a trainee needs to be seen by more than one examiner. One is not enough. You have to, a trainee needs to be seen by 2 or 3 at least different examiners before you get a good handle on their experience. And by the way, if you have that kind of faculty time, you're better off having each faculty member see the trainee with a different patient than getting all 3 together, or 2 together, for the same patient, okay? Because that allows you to sample multiple patients. Last thing is that this was a 2-hour event. And at least in the US context, no doctor spends more than 10 or 15 minutes with a patient. You just don't have the time to do that. As a consequence, this was a completely unrealistic task. So if you think about workplace-based assessment, it offers an observation of the trainee with multiple patients by multiple examiners on tasks that they do every day, realistic tasks. Okay? So workplace-based assessment drives and guides learning, provides feedback, creates learning, optimizes learning. From an assessment perspective, it allows you to get multiple patients, multiple examiners in realistic situations. Challenges, and there are many. In my experience, and in the US experience at any rate, not very many trainees are considered unsatisfactory. This is not a good device to make decisions about somebody. It's not a good device for summative assessment. It is a good device for formative assessment, for providing people feedback. So these are not so good for summative purposes. It's not a substitute. Second thing is that the standards that folks hold are going to vary across programs. They're going to vary across clinic sites. So again, this is not the sort of thing that you want to necessarily use for summative purposes, but you do want to use it to provide feedback. Implementation is difficult. We already talked about the fact that trainees who control who examines them and the patients are going to be biased. And trying to get faculty to do this is a real challenge. It's a lot of work. So there are real implementation difficulties here. And finally, the faculty or the methods. When workplace-based assessment does not work, it isn't because of the methods. It's because of the faculty, because the faculty are the methods. So if faculty are motivated and like this and want to do it and are interested in it, it works. It works beautifully. Faculty doesn't want to do this, faculty's too busy, fails. Okay? So this is all about the faculty, and they're the key piece to this. So we talked about workplace-based assessment. First, a series of common features. They cut across all the methods. We talked about 4 different methods, right? And then we talked about why they're good for learning and why they're good for assessment. Any questions? Good. Don't be sorry for a question. Never be sorry for a question. That's a good thing.
I'm a surgeon, so
you don't. That's not necessarily bad. I mean, you don't need to
looking
apologize
at our
for that
statistics
either.
for that. So part of the reason, well, speaking for myself, is one of the workplace-based assessment. It does involve quite a lot of effort.
Yes.
In terms of getting it done as well, and also a bit of writing as well on the forms. Our handwriting are just atrocious anyway. So we're looking at tying in with Education 4.0. Perhaps there is a more digital way of us inputting the workplace-based assessment. I mean, the training in the UK was still paper-based when I was doing it last time around. So that's one of the comments I thought about inputting the workplace-based assessment. The other thing is in terms of who's doing the assessment itself. Is it, you were saying multiple assessors, do they have access to the previous assessments so that we can have a look, or is it on your own individual assessments?
Okay, so there are apps now that will allow you to input this information from your smartphone. Are there not, Dr. Trudy? Dr. Trudy confirms. Folks are moving in the direction of making the data entry much easier and cleaner and not paper-based, because the paper used to fly all over the place. When we first rolled this out, we had triplicate paper. So we gave one to the trainee, the faculty kept one in the office, and it never got done. So that's the app bit. The second question again?
The assessors themselves, those who are making the assessment, do they have access to the other?
There's no need for that to happen. What I think ideally you would like is for you to judge the trainee in that moment.
Right.
Regardless, I mean, in an ideal world, you wouldn't even know them, but that's not ideal. I mean, that's not practical. But you don't want the other stuff, because that's going to send you off to looking for it. What I'd rather you did is find it on your own, and if it's the same, that's good, because you're going to have 3 or 4 different perspectives on that.
Then who would look at like we're saying that we want to see the progression, whether they're improving with their performance and all that?
So at this point, the way this is usually done is that there's some sort of clinical competence committee or some committee that takes all the information about a trainee at some point and puts it together to make either a personalized plan, as Trudy talked about, or to provide feedback to the trainee that cuts across all that. So there are a whole variety of ways to manage that, and that is one of the areas where technology will make a big difference, as Trudy indicated.
Another thing, last one, sorry about it.
Okay.
We tend to use...
Would you stop apologizing? Are you guilty?
Yeah. Hopefully not. We tend to use actually we tend to use some of our workplace-based assessment as a summative assessment, unfortunately. We use to put marks in them, and we actually inculcate them in our continuous assessment markings. And what's your opinion on that? I mean, and how can we improve, how can we improve that in terms of making things more useful and more beneficial to our students, obviously, to our learners?
When a student realizes that something is going to be used to grade them, their reaction to that event is significantly different than if they know that this is not going to count. Okay? So but there are people who have to use this for summative assessment in some settings, and I understand that, and you just do the best job you can with that. But one of the things that I think is important is that it's identified to the student when it is formative and when it's summative, and that you offer a mix. Okay? So that the formative assessment in some sense is a preparation for the summative assessment using similar methods. But they have to be clearly identified to the students. Otherwise, you're going to get a whole different reaction. Like, why didn't you give me a 7 instead of a 6? Don't you think this was really a 7? And so you end up in a bad place if it's summative.
Okay. Thank you very much.
Sure.
Prof. Incidentally, I'm a surgeon too. But without being sorry, I have 2 questions to you. My question 1 is, which I have been asking to all those champions in workplace-based assessment, and yet to get a right answer. The question is, about the DOPS. As a surgeon, I believe the DOPS are direct observed procedural skills, and considering the workplace, should be a real procedures. But often the situation arises like, for example, all undergraduates supposed to have skills and mastery on tracheostomy or intubation. That's a need for undergraduate. But we often hardly find the situation where they can be hands-on doing these procedures. There are multiple other procedures which cannot be done hands-on because the resource is not available, or they cannot be trusted to do directly on patients. So we bring this to a mock situation. For example, clinical skills lab, intubation is very good. Tracheostomy can be done if model developed. But the question is, we are moving from the workplace to a mock situation. Will DOPS still be a DOPS if I do it in a lab situation?
So I would just use a different name. It's precisely the same thing. I would use a different name. The other thing is that with real patients, you do get to see some things that you don't necessarily see in the sim lab, like how they explain the procedure and asepsis and all those kinds of things that are a little more challenging in a simulation setting, but not perfectly so. So, you know, the name of this in some ways doesn't matter. This is not, as I said, this is not rocket science. So you need to be able to take these things and make sense of them and use them the best you can in your environment. So if you want to call that DOPS, it's all yours.
Yeah. The second question is about the everything fall on psychometrics end of the day, right? Reliability, validity. So what makes mini CX, DOPS, or any other procedure reliable? What number makes, or is it the number matters, or psychometrics matter in terms of reliability, validity? At the end of the day, we have to report it to the faculty training. So what really makes it reliable and well?
So I think the things that we just described are really going to drive the validity and the reliability. So the first thing is the number of examiners. Second thing, actually the first thing is the number of patients. Second is number of examiners. Third, as long as the task is realistic and it's set in a workplace, you don't get it much more valid than that. Okay.
Thank you very much, Professor John Norcini. So now I'd like to invite Professor Vishna to present a token of appreciation.